We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally, escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Let's take a look at available options for definitive treatment of MSSA bacteremia. So we have a lot of antibiotics that have in vitro activity against MSSA, for example, vancomycin, nafcillin or oxacillin, which are anti-staphylococcal penicillins. So these are similar to methicillin. Cefazolin, which is a first-generation cephalosporin. Ceftriaxone, which is a third-generation cephalosporin. And piperacillin tazobactam, which is also in the penicillin class. Now, the standard of care for treatment of MSSA bacteremia is to start with IV antibiotics. So all of these agents are available as IV only. And when you compare these, you will see that vancomycin is associated with nephrotoxicity. So is nafcillin and oxacillin. Nafcillin's more than oxacillin, but regardless, both of them are associated with nephrotoxicity, whereas cefazolin is not associated with nephrotoxicity, neither is ceftriaxone. Piperacillin tazobactam has also been associated in observational studies with nephrotoxicity. Now, with hepatotoxicity, specifically elevation of transaminases such as ALT and AST, you will see that nafcillin or oxacillin significantly increase transaminases, whereas the rest of these do not significantly increase transaminases. And when it comes to cost, most of these are pretty affordable with the exception of nafcillin or oxacillin. So these are pretty expensive in the range of hundreds of dollars per dose. So between $100 to $200 per day. Now, what we have seen in observational studies, and this is because we do not have head-to-head randomized controlled trials to compare these. So what we have is observational studies, is that nafcillin or oxacillin are actually superior to vancomycin in regards to clinical outcomes. So vancomycin is actually inferior to these as well as cefazolin, whereas cefazolin, nafcillin, or oxacillin have similar efficacy. And of course, you will see that the advantage goes to cefazolin because it is better tolerated, so it's less likely to cause nephrotoxicity and hepatotoxicity, and it's more affordable. And also the dosing is more convenient. So this is 2 grams IV every 8 hours, so only 3 times a day, whereas nafcillin and oxacillin need to be given every 4 hours, or you can do the entire 12 grams as a continuous infusion. So, pretty much around the clock. So that's inconvenient. Now, historically, nafcillin or oxacillin have been considered the standard of care for MSSA bacteremia. However, in recent times, cefazolin has become a better option. So, cefazolin pretty much everything that you look at has a better profile compared to nafcillin or oxacillin. Now, there are other beta-lactams that also have activity against MSSA bacteremia, for example, ceftriaxone and piperacillin tazobactam. And a lot of patients may be on these agents empirically, but when the culture results come back and it is MSSA, it is important to switch the patients to either cefazolin or nafcillin or oxacillin, because again, based on observational studies, both ceftriaxone and piperacillin tazobactam had inferior effectiveness compared to cefazolin or nafcillin or oxacillin. MSSA bacteremia needs to be treated with IV antibiotics. Obviously, the site of infection is in the blood, so IV administration will take the antibiotics directly to the site of infection. The question is, once the patients start to improve, can we transition from IV to PO? And some experts do not recommend oral step down as a routine practice, and this is primarily because the evidence for IV to PO transition is based on observational studies. However, in 2024, the Sabato RCT was published. This study evaluated oral trimsulfa or clindamycin after 5 to 7 days of IV antibiotics in uncomplicated Staphylococcus aureus bacteremia, and in this study 92% of patients had MSSA and 8% had MRSA, so this is essentially applicable to MSSA bacteremia. And this was done in patients who were hospitalized due to Staph aureus. These are patients with low risk for complications, so this is uncomplicated bacteremia. And essentially, after 5 to 7 days of antibiotics, patients were randomized to either receive oral antibiotics or continue IV therapy. And the primary outcome was 90-day Staph aureus bacteremia related complication, which was a composite of relapsing bacteremia, deep-seated Staph aureus infection, or mortality. And what they found was that in the oral switch group, 13% of patients had the primary endpoint of complications within 90 days compared to 12% in the IV group. And this was a non-inferiority trial with a non-inferiority margin of 10%. And it was essentially able to show that oral switch was non-inferior to continuing IV therapy. Now you can see the results for other outcomes, including the components of the composite. Of importance is death due to Staph aureus bacteremia, and you will see that this was also non-inferior. So although 2 people died in the oral switch, there was no significant difference between the 2 groups. In other words, oral switch was non-inferior to IV. So this could essentially change current practice and allow for patients who have uncomplicated MSSA bacteremia to be transitioned to oral antibiotics, specifically either trimsulfa or clindamycin. Now let's take a look at pathogen-directed therapy for bacteremia. First, let's consider methicillin susceptible Staphylococcus aureus or MSSA. So for MSSA, treatment of choice is either an anti-staphylococcal penicillin such as nafcillin or oxacillin, or cefazolin. And these are considered first choice. They are all superior to vancomycin for definitive treatment of MSSA bacteremia because they have mortality benefit. So, if patients receive vancomycin for pathogen-directed MSSA bacteremia, they're more likely to die compared to receiving these. Now, cefazolin is first-generation cephalosporin, and compared to nafcillin and oxacillin, cefazolin is a much safer option. So both nafcillin and oxacillin are nephrotoxic. So, patients are more likely to develop nephrotoxicity compared to receiving cefazolin. In addition, nafcillin and oxacillin are more likely to be hepatotoxic, so they are more likely to result in increased AST and ALT, so transaminases. And when you look at the dosing, I haven't listed the dosing for these agents here. Cefazolin is dosed every 8 hours, whereas nafcillin and oxacillin are actually dosed more frequently, every 4 hours. So it makes it more difficult to administer. Cefazolin, much better option. Now, of course, if somebody cannot tolerate beta-lactams, then vancomycin would be an alternative option for them. For MRSA bacteremia, drug of choice is vancomycin or daptomycin. Vancomycin is historically more affordable than daptomycin, so people most often use vancomycin. Now, that is based on directed cost of acquisition when you compare vancomycin to daptomycin. Now, if you consider that vancomycin requires therapeutic drug monitoring, so you essentially need to pay a pharmacist to basically get vancomycin levels and make adjustment, one could argue that daptomycin might be more cost effective. But regardless, either vancomycin or daptomycin would be treatment of choice for MRSA. And the reason linezolid is not considered drug of choice is because typically with MRSA, we need to treat for at least 2 weeks. And linezolid becomes problematic when you treat for long periods because of adverse effects. So vancomycin and daptomycin are much better tolerated, and they're considered drugs of choice. Now, however, everything we have listed so far is only available as IV. One advantage of linezolid is that it is available as PO. So it would make it easier when transitioning from IV to PO. Now, in general, with MRSA, for the most part, we treat the entire duration as IV. In the POET trial, no patient had MRSA. So although, there is some evidence for oral treatment of gram-positive bacteremia, none of those patients had MRSA. So, pretty much standard of care right now for MRSA, for the most part, is IV treatment. Now, for VRE, which is vancomycin-resistant Enterococcus, vancomycin, of course, is no longer an option because this is resistant to it. So now you have daptomycin or linezolid. And, with VRE, you don't need to treat as, for very long times as we do for MRSA. So typically shorter duration of treatment. Linezolid becomes an option. And when you compare daptomycin to linezolid, daptomycin might have an advantage because, for one, linezolid is bacteriostatic, but daptomycin is bactericidal, so has more potent activity. But also, daptomycin is easier because it's in normal renal function, it's administered once a day, whereas linezolid is typically twice a day. But on the other hand, again, linezolid has an oral option, whereas daptomycin doesn't. So, there are pros and cons, but regardless, both of them are considered treatment of choice for VRE bacteremia. And so these were gram-positives. When it comes to gram-negatives, one thing that's very important is treatment of ESBL bacteremia. And carbapenems are considered first-line treatment for ESBL bacteremia. In fact, meropenem was shown to be superior to piperacillin tazobactam in randomized controlled trial. So people were less likely to die if they were receiving meropenem compared to piperacillin tazobactam. So there's mortality benefit with carbapenem. So now they are considered first line for ESBL bacteremia. And cefepime should be avoided because of increased risk of mortality. And this is, regardless of susceptibility. So if the patient has blood cultures growing, let's say ESBL producing E. coli, and is susceptible to piptazo and cefepime as well as meropenem, we should avoid using cefepime even though it is susceptible, and we should avoid using piperacillin tazobactam, and we should use a carbapenem because of the mortality benefit. And lastly, other gram-negative organisms, considering they are not multi-drug resistant, because, there are other resistant scenarios that are beyond the scope of this lecture. So we will not cover carbapenem-resistant Enterobacterales. I will refer you to IDSA guidelines for treatment of those infections. Multi-drug resistant Pseudomonas, Cinetobacter, and other multi-drug resistant organisms we will not cover in this lecture. So other gram-negative organisms that are pretty much easy to treat, things like a normal E. coli that's not resistant to multiple drugs, or even Pseudomonas that's not resistant to multiple drugs. So essentially wild-type gram-negative organisms. You essentially choose the narrowest agents based on susceptibility results and PK/PD properties, meaning you want to choose agents that have good concentrations in the blood. For example, you want to avoid tetracyclines in general, because tetracyclines have a high volume of distribution, meaning that they distribute throughout tissue, so very little concentration remains in the blood. So if your treatment, if the site of infection is in the blood, you actually want the drug to stay in the blood and not go to other tissues. And things like, doxycycline, tigecycline, these are antibiotics that do not achieve high concentrations in the blood and should be avoided. Now, for oral treatment of gram-negative bacteremia, there are certainly more data when it comes to oral IV to PO switch for gram-negatives. And in general, we want to use high bioavailability drugs such as fluoroquinolones and trimsulfa. So you can see trimsulfa and fluoroquinolones have high bioavailability. Now that's preferred. Occasionally, if the patient cannot get these, then and only then oral beta-lactams may be considered, but you do have to make sure that you give a high dose to make sure you get enough concentration in the blood. So these are pretty high dose. If you are to use amoxicillin, you want 1 gram every 8 hours, or if amoxicillin clavulanate, it's at least 875 milligram, ideally 1 gram PO every 8 hours. If it's cephalexin, 1 gram PO every 6 hours. Now these three are preferred if you are to use an oral beta-lactam, and there are less data for the other oral. So if it's best to avoid the other ones due to lack of enough studies showing that you could get enough concentration with cefdenier, cefodoxime, and cefadroxil. But if you cannot achieve, if the patient cannot get these other, you could potentially use this, but you have to make sure that you use higher doses than normally we use. So you want to optimize the dose.